evening. Today, I will start by the station, which is applied surgical science and critical care. It is one of the 3 stations. It is one of the difficult station in the exam. Okay. So you see the screen now? The screen is clear? Okay.
تمام.
Yes. Yes. Okay. So it is important before we start the exam, you see this the distribution of the stations. You can see here applied surgical science and critical care. We have 1, 2, 3 station. The 2 station of them is interpretation of data and lab investigation. The third one is critical care. If you see the mark 12 mark for clinical knowledge, 4 for clinical clinical and technical skill, and another 4 for professionalism. Okay, so this is 12 4 4. So 4 for clinical and 4 for professionalism. The same here. So the station, again, the 2 station is interpretation of data. Data can be chest X-ray, ECG, arterial blood gases, respiratory function test, and the lab investigation, including full blood count, liver function, etc. The third station, one station about critical care management. Okay, so again, 12-4-4, we don't have communication skill here. We have clinical skills like examination and professionalism. This example of the station. This is the station have a lot of debate, and this debate come from misunderstanding of a student. I just read the station, and after that we can ask one to represent it. You have been asked by staff nurse to review a patient. Mr. Charles, who is underwent major abdominal surgery. The surgery is right hemicolectomy for cancer ascending colon. Of course, it is, you know that if you are working surgery, right hemicolectomy is not associated. We don't do colostomy and right hemicolectomy. We just make ilio transfer anastomosis. It's different than left hemicolectomy, which you have colostomy. 10 days ago, so they have the operation 10 days ago, the patient complained of some intermittent right-sided chest pain, fever, abdominal pain. You will find the patient observation chart available. You will take task is to make detailed clinical assessment, and you don't need to discuss finding as you go along. So again, what we have, I just mark it. So this is the same script. I just make it in yellow. So we review the patient. So we don't mention it is clinical examination. We don't mention it is history taken. It is review the patient. And you have observation chart and the investigation. You need to have look on it. And detailed clinical assessment. So this is important to know what is the station for. So after 6 minutes, you will ask it to present your finding and discuss them with the examiner. Again, this station is test clinical examination skill, not history taken, and you should restrict your talking with the patient to issue relevant to your clinical examination. Again, this task, you ask it by the nurse to review a patient, or you can ask it by anyone to pre-op or post-operative assessment, or evaluation of fitness of operation, or you meet the patient in pre-admission clinic and you are houseman or SHO, senior house officer, in surgery or in anesthesia. Okay, so it is clear. So I bring again the first scenario. So anyone now tell me what is your expectation from this station? What you expected?
Either pneumonia.
No,
it can
what
be
your
pulmonary embolism.
expectation is what you need to do in this station.
So first, I have to address the patient to just check the abdomen just light palpation to exclude any anastomosis leak or anything. And then I'm going to
Okay.
start by addressing the patient from his hands to see the capillary refill, the pulse, and then address the breathing. I'm going to speak to the patient to see if the patient is his airway is patent, and I'm going to give the patient
I
oxygen.
just need to ask you the first question. Is this station is related to which topic in exam? First,
To
what
critical
is
care.
this station? Critical care. Okay, so it is basic surgical sign. All right. So you start first by check the abdomen.
Yes, I'm
Okay.
going to
So
extract the patient from
All
his
right.
leg.
Okay. So go on. What else you need to do?
Then I'm going to supplement the patient with oxygen. I'm going to
Okay.
just see the pulse, the rate, the rhythm, the capillary refill. I'm going to see any
So
signs of
how to do that? See the pulse.
the radial pulse and the capillary refill distal in
Okay.
his.
So you feel the pulse of the patient.
Yes.
Okay. All right. What else?
I'm going to look for the eyes for any discoloration. I'm going to look for the mouth and for central cyanosis. And then I'm going to check the respiratory function of the patient. I'm going to
How
listen.
to check respiratory function to the patient?
I'm going to just listen, percuss, and just with the stethoscope to assess the bilateral air entry.
Okay.
If it's present in the station, if it's available, then I'm going to use it. And then I'm going to just take a look for the news chart or the observation chart and the investigation that were done to the patient. And according to the score, then I'm going to decide what we'll do. And the
which
patient
score? According to which score?
news score.
Say again.
News score. NEUSWS.
NEUWS. What is this score for?
New score is it's for the observation of the patient. It has it contains the respiratory rate, the blood pressure, the pulse of the patient, and the
okay. Go on.
temperature. Yes. And by this, I'm gonna see if there is any abnormality in the
you
score.
mean just a minute, doctor. You mean that this new score, you're looking for respiratory rate, pulse, and what?
I'm gonna look for the respiratory rate, the pulse, if the patient has fever or not. It's just the observation chart of the patient.
No, I just mean I don't understand what is this new score. It is NEUWS.
NEWS.
NEWS. Okay, that newspaper.
Yes.
Okay, so all right. Okay, go on. Okay.
And then I'm gonna see the investigations that were done to the patient, check the ABG and the serum lactate, check the PO2 and PCO2, and if the patient did ECG recently or any cardiac enzymes, full blood count to see if there is any discrepancies before perioperative and postoperative. This will account for, and I'm gonna ask for new investigations as well to check the patient clinical status.
Okay. Finish?
Yes.
Okay. What is your diagnosis?
My diagnosis will most probably be either pulmonary embolism, pneumonia, atelectasis post-operative, or an anastomotic leak if the patient has a drain. If it's clear, then most probably it's not. And if the patient examination is free on the abdomen, then it's most probably it's not going to be an anastomotic leak.
Okay. All right. Finish. Okay. So I start one by one. Okay. So first, I think you are not working in general surgery, or what is your specialty?
I'm an oncosurgeon, but yeah, I worked as
oncosurgeon. Okay. So if we have left hemicolectomy, which is common in exam, can anastomotic leak occur?
No.
No. Why?
Because I've already I have an end colostomy outside of the body.
It is not endocolostomy, it is double barrel colostomy in the right side. So whatever the condition in the hemicolectomy, anastomotic leak is never happened because simply you have covering colostomy. Okay? If anastomotic leak happened, it occur after how many days?
Most probably just immediate in the 24 hours or 3
No,
days.
I mean that what time the patient presented by anastomotic leak. Suppose you make colostomy, you make colectomy without colostomy, and the patient have anastomotic leak. Anastomotic leak to occur, it is occur in the 5th day or 6th day, what we call it 5th day fever. Okay? So in both scenario, because the original scenario is left hemicolectomy, I change it because I don't have a picture of colostomy, so anastomotic leak is not considered. Okay? Second, about professionalism, you mentioned new score.
Yes, sir.
Okay, so suppose I am the examiner. You expected the examiner knows this score.
No, it's just the vital chart, the vital data chart.
But you have name.
Yeah, they call it that way. I don't.
Okay, so it is if you mention in this way, you will lose mark in the professionalism, because if you say something is not common, so it is not evidence-based medicine, so it is wrong. Okay. And also the examiner maybe have interest to know what is this. All right. So you go to through the all this, but it is good. I just take it step by step, and we can compare your answer what you expected. What you expected this station failure rate? It is high, low. What you expected?
I think it's high due to the professionalism, I think.
Okay. Usually it is very high, yes. Okay. I just take it step by step, and after that we discuss. So again, your task is you asked by staff nurse to review the patient. So that usually it is something like evaluation of the patient. So it is not a clinical physical examination, although you will examine the chest. It is not history taken, although you need to ask the patient some question, but don't analyze if the patient have pain, no need. Communication skills, no, because you don't affect about it is affect daily activity. So next, what in the room? In the room, we have a patient, of course. We have a person in his name, vital sign chart. We have oxygen. We have a stethoscope. We have hand gel tissue and wound dressing for the abdomen or colostomy bag according what we choose in the scenario. Of course, who is speak to me? By the way, just to remember, what's your name?
Hisham, Muhammad Hisham.
Muhammad Hisham. So, Dr. Hisham, okay, so you speak in professional way, but I tell you what we expected from us to do. So first you introduce yourself to the patient. Okay, we agree, so this is one. After that, you ask a quick history about dyspnea or sopnia, proximal nocturnal dyspnea, any history of bronchial asthma, smoking, chest pain, MI, or patient on oral anticoagulant. Yeah. After that, in the management, I just stop one by one. So you put the oxygen mask. Okay. So what is the next step, Dr. Hisham? If you put an oxygen
Just
mask.
adjust the flow meter. Adjust the flow meter
All
to
right.
4 to 5
All
meters.
right. Okay. So the next step, you adjust the flow meter between 3 to 5. Of course, the maximum is 15. We don't use, so adjust the flow meter. You missed to tell me that. Okay. After that, you put the pulse oximeter. I think you speak about it.
Yes. Sir.
Okay. After that, you check the intravenous fluid and the intravenous line and cannula. Okay. Of course, we connect it to the patient, but it is not a true connection. It is just to put a plaster and the cannula, but we don't put inside the vein. So don't try to make the drip patent or see the flow of the drip. After that, looking for vital signs. Where you found the vital sign, Dr. Hisham?
I'm sorry?
Where you found the vital sign?
I've already tested the pulse of the patient and as
No,
well as in the vital chart.
where, doctor,
Vital
relax.
chart.
Where in the place? Where you found it?
Next to the patient or in the just in front of the patient bed.
Okay, so they usually either in the food bed of the patient, like traditional vital sign chart, or in sometimes an exam we put in the wall just to be apparent to you. So you're looking for vital. If you see any movies, all the Arabic movies, the doctor usually make a word round. The first thing he look into vital sign chart. Of course, nowadays not most of hospital have this, but it is important. After that, you look into the chart. You have a real chart, looking for pulse, looking for temperature,
Sir,
patient
this
have
is
fever.
the total
Yes.
new score. Just look at this is the new score. This is exactly the score.
Okay, so Dr. Hisham, according to your background, I don't know what is your background, but okay, no problem. All right, I speak to it at the end. Okay, so
Okay.
this is the vital sign chart. So this is the temperature, this is the oxygenation, the blood pressure, heart rate. Sometimes you have some categories here, or orientation, or pain score. After that, examine the chest. When you examine the chest, doctor, you need to do inspection, palpation, percussion, and auscultation. So it is a classic way to examine the chest or heart and pulse. So inspection, palpation, rapid percussion, and auscultation from front and back. Okay. After that, looking for arterial blood gases. So again, what we manage here in this station, we take it in the order, like quick history, examination, looking for investigation. During this period, the examiner not to speak to you. Okay. Of course, I miss here in examination looking for central cyanosis. So it is important you miss it. So I miss it. So it is important to examine for central cyanosis or general assessment. After that, we looking for arterial blood gas. Dr. Hisham, if you look into arterial blood gases, what is your impression?
Here he has caloses.
Of course, the normal value is written in exam. So we have a normal value, like sometimes in kilopascal, sometimes in millimeter mercury. So what's your diagnosis?
Respiratory alkalosis.
Respiratory alkalosis, because we have low carbon dioxide, low oxygen. This is bad conditions, so low bicarbonate. Of course, pH is alkalosis. Of course, this is respiratory alkalosis. Can occur in pulmonary embolism due mismatching between ventilation and perfusion in the lung and increased respiratory drive causing due to hyperventilation. After that, looking for ECG. So what you look in ECG, what is your diagnosis here?
Here, this is the front. The top one is AF. The other one is normal. So
Okay. All right. Or this one, what is this one?
let's see. Q3. This is pulmonary embolism. So it's a prominent S wave with an inversion T and Q.
Okay, so you can find this is what called S1, Q3, T3, pattern of acute cor pulmonale. So S1 in lead 1, Q in lead 3, inverted T wave in lead 3. All this indicated right heart strain or B pulmonale. Sometimes it is pulmonary embolism. After that, you look into the wound. Okay. Usually just inspect the wound. If this patient have right hemicolectomy, so they have something like here, no colostomy. If patient have left hemicolectomy, so you have colostomy. If patient have colostomy, possibility anastomotic leak is never happened. Okay, so the only patient have left hemicolectomy without colostomy. If you look into the previous exam, they mentioned that the patient have left hemicolectomy with colostomy, so anastomotic leak is not in differential diagnosis, although most of the students say it is anastomotic leak. After that, sometimes if the patient have Hartmann procedure, also we don't have anastomosis, so he just have diverticulitis because one of the scenarios is diverticulitis. So we just resect the area and put the two enta outside, what we call the Hartmann procedures. After that, examine the cuff muscle to exclude deep venous thrombosis, because maybe this patient have, as Dr. Hisham mentioned, pulmonary embolism due to postoperative deep venous thrombosis. Okay, so in this patient, if you describe the patient, have dressing in the lower abdomen. Abdomen is painful, so not allowed the candidate to examine. You know why we say the abdomen is painful? Why we mention the abdomen is painful?
So not to allow the candidate to examine it?
Yes, because no time.
Sorry
If you
to
take a
interrupt.
time to examine the abdomen, it take a time. So we don't have a
Yes.
time to examine the abdomen, so we say it is painful. Okay? So it is not an anastomotic leak, by the way, because not allow the candidate to examine, because if he examines the abdomen, he lost the time. Of course, the patient have pain, have difficulty breathing, have hurt in breathing. Of course, if you ask the patient, you need to ask the patient about oral anticoagulant. The patient tell you about anticoagulant. Of course, they have limited inspiration or something like that. And when the candidate examines the calf muscle, the patient has little pain. Okay?
Okay, sir.
So after 6 minutes, the examiner asks you, can you summarize? So you can summarize what you tell me.
Okay, by inspecting the patient had his post-operative. I've concluded my examination of X, who is X years old, with a history of his 10 days post-operative right hemocolectomy with primary anastomosis.
No, this patient, doctor, this patient is right hemicolectomy. Yes, primary anastomosis. Yes, okay, correct. Okay, go on.
By inspection, there was a dressing in the right iliac fossa. There is no oozing. There is no issue. But the patient has a painful abdomen. So we started doing the CCRIS protocol, assessing the patient vital data.
What is CCRIS protocol? You mean?
Care of the critically ill surgical patient.
What is definition of critical ill surgical patient?
Critical. The patient that is. I don't know.
Okay. Definition of critical ill surgical patient is patient have one or more organ failure.
Okay.
Okay. I see that most of the candidate in exam consider the patient is critical ill surgical patient. Okay. Not critical ill surgical patient have special criteria. Okay. Go on. No problem. Go on. What else?
So I've taken a simple history from the patient. The patient complained of right-sided chest pain.
Yes.
Yes, and by reviewing the vital chart and data, the patient is tachycardic. He has on the pulse oximeter, and I've supplied the patient with 100% oxygen through a oxygen mask on 3 to 5 liters of oxygen.
So doctor, in your hospital, is the oxygen in the container in the wall is 100%? Okay. If you have a mask, I just give you a picture. I give you a picture here. So if you look in to any patient take oxygen in your hospital, you have oxygen in your hospital. If you ask the nurses, so what is the percentage of oxygen we give to the patient? What is the answer?
I think most probably they will have no idea.
All right. Okay. Is anyone know what is the level percentage of oxygen we give it to the human or patient?
I think 35%.
All right. No. I just make it again. If you give this patient 100% oxygen, what happened to him?
There's oxygen toxicity. I think
oxygen toxicity. We don't give the human 100% oxygen. We give 60 to 70% oxygen. So how come we get how we give him 60%? How it come? In your hospital, if you work in hospital, how to give the patient 60%? How to make it 60? You don't make it 60. Actually,
non-replaceable muscle.
No, make it easier. Usually, the oxygen cylinder is 100%, but the oxygen cylinder is the first floor in the central station, and they come to the patient in the second floor. When they come to the patient, they mix it with the air in the pipe system before they reach the patient. So they reach the patient 60 to 70. If you are in hospital, they use direct from oxygen. What is the doctor say now? What is type of oxygen you give? What is type of mask? What we called it?
Non-rebreathable mask.
Say again.
Non-rebreathable mask.
Yes, none. What?
Rebreathable.
Okay. So
Breathable.
usually in pediatrics, they use that, but usually the oxygen you give it is 60, 70%. Just to say oxygen. Okay, what else? Just continuous?
Okay, and the patient is hypoxic. I've reviewed the patient vital chart, the patient investigation. I found that the patient is having a respiratory alkalosis, and the patient is with the ECG. He has the pattern of most probably pulmonary embolism with tachycardia as well.
Okay,
And I've
so
examined the pulse, and they are painful for the patient. So.
all right. So if you miss to measure to usually you can miss. So his question started after 6 minutes. Summarize the finding. If you don't make the Hoffman test, so the examiner asks you other examination would you wish to perform. So I need to check the cuff muscle. Okay. What is the possible again? What is the possible underlying cause?
The deep venous thrombosis due to the presence of the patient is hypercoagulable due to the cancer itself, and maybe dehydration, and as well maybe sepsis post-operative.
Okay. So forget sepsis because we have something of sepsis. We don't give to you serum lactate and other. So it's most probably pulmonary embolism with you deep venous thrombosis. Okay. So is any special investigation you need to do?
The gold standard in diagnosis of pulmonary embolism will be a CT pulmonary angiography to see the affection of the pulmonary vasculature.
Okay. All right. So what is other option of management?
The options for management, it depends on the patient vital status and the hypoxia and the degree of the pulmonary embolism. First, we're going to start the patient. We're going to supply and maintain the oxygenation of the patient. Second, we have to provide the patient with anticoagulants in the form of low molecular weight heparin or unfractionated heparin. And then we're gonna, and if the patient has a massive pulmonary embolism, then we have to consult cardiology to our interventional radiology to do a percutaneous embolectomy to reperfuse the lungs.
It is common to be lung percutaneous embolectomy is common to be done in your country or your hospital?
It's not common.
Okay, so if something not common, don't mention it in exam. Okay, so can be anastomotic leak?
No.
Why?
Because the patient presented with a pain 10 days post-operative, and it's
yes, go on.
And it's a right hemicolectomy with primary anastomosis, and the patient. But should I say that the patient abdomen is painful, and he didn't allow me to examine it? So can it be anastomotic?
No, the examiner he see no, it's not anastomotic leak because usually I just make it right hemicolectomy because if I mention it is left hemicolectomy, I must put a colostomy bag. Okay. So I recognize that. So inshallah, in next exam, we can put a colostomy bag just to be mimic the truth. Okay. So now the last question. Shortly after the examination, the nurse staff call you and the patient collapsed on the ward and recordable blood pressure and scrubbed. You are scrubbed in theater in abdominal aortic aneurysm repair. What would you do? What you will do now?
What I will do? If I have a colleague that can cover me during the scrubbing, and I'm gonna check for the patient vital data and I have to call the ITU registrar and just assess the patient and
no, doctor, just relax. What is the aim of this question?
How will you deal with a critical patient while you're
it is not how to deal with a critical patient. This question is how to deal with your situation.
Okay.
How it is the question in management, not in the management of you, not the patient. You understand?
Yes, sir. Okay.
You are the doctor responsible. You are in abdominal aortic. You know, abdominal aortic aneurysm is not easy operation. It is not appendix, and can you leave your consultant? Okay. So from management point of view, management, not management of the patient, management like from administration point of view, what shall you do?
I need any doctors to review the patient in the ward if I cannot review him.
Okay, no, you can or cannot. It is impossible to leave the abdominal aortic aneurysm. So what is your solution?
So I have to find the senior that is on call, or he's not scrubbed, to tell him to go and see my patient.
All right.
To
Okay.
see the patient.
So the answer: don't leave the theater. Ask the nurse to make crash call, or any team is free. Suppose is one attends the surgery just to supervising. Anyone is free. Ask him to go, or can scrub instead of you. Okay. So this is like social question. It is not. We don't ask about how to do with the patient. It is like how to manage the situation. Okay. You agree?
Okay. Yes, sir.
Okay. All right. Of course. So I just review just as easy. This is one of the common stations. So you just introduce yourself. You ask about dyspnea or sopnia, proximal nocturnal dyspnea, bronchial asthma, smoking, chest pain, patient in any anticoagulant, oral anticoagulant. The management start by give oxygen. Oxygen is usually 60-70%. The flow meter in exam, we usually, most of the exam in hospital, so they have this flow meter, so you need to adjust it. Of course, you need to connect it, or connection is done. Put the pulse oximeter and check the intravenous fluid, what they giving to the patients, you must know that. After that, looking the chart of vital signs, either in the bed of the bed or the end of the bed, or in the wall, according to the station. We have this chart, which your friends say it is new chart. And
Doctor,
yes,
can I check all vital signs and vital charts after end of my examination?
you can
I
do
need
anything, no problem. If within 6 minutes you can do anything. But
yeah,
usually you would check the vital signs before, but no problem, because it is supposed to start by general examination. So pulse, temperature, blood pressure, but no problem at all. You can do
uh,
what you wish to do.
okay. As I mentioned that when I check the respiratory rate, I can say that by in my language. I will check the respiratory rate. When that's the examiner say to me, it is a check and it is in a vital sign.
No,
So
I
I
don't understand. You need to check the respiratory rate by yourself.
yes
No, we
to
don't
me.
have a time, because it is need half minute or 1 minute, so
I
don't have a
need
time for that. But it is
don't stop.
everything. This is why we have a vital sign. Say again.
I think Dr. Serene, he means that يعني, to talk while he's examining the patient, or while
You
he's
can
managing the
talk, no
patient,
problem.
to
You
talk,
can talk, no problem. You can
to
talk,
to, to
no
make the
problem.
examiner, like the examiner understand what he's doing, or what he's.
Yeah, but if you put a stethoscope, he knows that you make auscultation. If you put
No,
percussion, he knows that you
he
make a
means I
percussion.
need to check I will look to the chart to check the respiratory rate, to
No,
check the blood
I
pressure,
see
to
you
check
that
all
you
that.
are looking to the chart, because
Okay,
you take it and look it rate. We don't do like this. So you look at the chart.
okay,
If you look into the chart, so you write in notes, or you know that blood pressure is
yes,
low, temperature I think is high here, oxygen
yes,
saturation is something. So you can do everything.
okay.
Up to
But
you, no problem.
don't mention to the examiner anything I will do.
No,
That's
no, you
true.
can mention. For me, for example, if I am the examiner, I prefer to mention to me. Because sometimes the student do something, I don't know what they are doing. But some examiner is not bother. So it is different from examiner to examiner, but most of the examiner is prefer to speak. Some is not worried about this.
Okay.
Okay, doctor.
Okay? All right.
Usually they have a two wide pool cannula, or I should mention I want to insert a two wide pool cannula and insert urinary catheter to
No,
uh,
doctor, I just need to tell you what you need to do. If you don't do, you have mark. If you need to insert a cannula, we give you cannula to be inserted.
أصلا. No.
Okay, is what is connected is connected. You have a cannula, you have fluid, so you can look to the fluid. But if you need to insert a cannula, we give you cannula, no problem. If you have a time.
يعني تمام.
You don't modify the station. It is
Understood.
according the station. Okay.
تمام.
All right. So I think usually we put two cannula, by the way. So after that, we go to inspection, palpation, percussion, auscultation. As you mentioned here, in quick way, make auscultation from front and back, look into arterial blood gases, look into ECG, whatever, look into the wound. Don't examine the abdomen, of course, or if you try to examine, he don't allow you to examine, and examine the cuff muscle. If you forget it, the examiner tell you need to examine the cuff muscles. Okay,
May I ask a question, sir? In
you can
regard of the
ask.
patient, yes, when do I supplement the patient with 12 to 15 liters of oxygen through the mask in only
No,
trauma
if the
patients?
patient in bad condition.
Okay, and
If
this
bad
is
condition, like
determined by,
suppose the patient in trauma and the oxygenation is not good, so you can increase the oxygenation, and your guide is pulse oximeter. If the patient not
yes.
improve, you put in ventilator, because the indication of put the patient on ventilator is patient not response to oxygen therapy.
Okay, sir.
All right. So this is common station in exam. Failure rate is high. Uh, Again,
Why, Dr. Serene? Why the failure
I,
rate is
I, I,
high?
I tell you now, I tell you now,
Okay.
because the student usually they have like mimic the same station, because in the stations in the exam we have a little change. So we can change the ECG to BAF. We can change the blood gases, because in pulmonary embolism also can be respiratory alkalosis. Sometimes it can be respiratory acidosis. So they have some trick. So if I go to the second scenario, the same scenario, but we have a little modification. Okay. So what I changed it is the same. You have been asked by staff nurse again to review a patient, Mr. Charles, who's underwent a major abdominal surgery, Hartmann procedure for colonic diverticulitis 3 days ago. The patient complained of the intermittent right-sided chest pain, fever, mild abdominal pain. You will find the patient observation chart. You take detailed clinical assessment, and the same as we mentioned before. So Dr. Hisham again, because he started by the first station.
Yes,
What
sir.
is your opinion in this station? By the
This is
way,
most
Dr.
probably,
Hisham, you entered the
yes.
exam before or not?
No, I didn't.
No.
Sir.
So what is the difference between this and the previous station?
The duration post-operative, this is 3 days, so it's most probably going to be lung related to either pneumonia or atelectasis.
Okay. So can be an anastomotic leak.
No.
No.
Okay. Why?
Because we have a diversion, we have a colostomy outside of the patient, and it's
This is
3 days
colostomy on right side or left side?
the left side,
Why it is left side?
because it's a colostomy.
No, colostomy can be right or left.
Yes, because this is in the descending colon.
Because usually Hartmann procedure for what is the common site of diverticulitis?
The sigmoid.
Sigmoid, so left side. So of course a cancer can occur anywhere, although it is common in left side, but diverticulitis is common in the left side. So we have left diverticulitis, and the operation can be left hemicolectomy with colostomy, but this patient may be difficult to have this anastomosis, so we put the two ends together. So it is Hartmann procedure. So okay, so back again, this is the Hartmann procedure. So, Dr. Hisham, how to manage this patient? What is your
So
diagnosis first? What's your diagnosis now?
pneumonia or atelectasis post-operative.
You mean chest infection, can be lung atelectasis. So what you will do for this patient?
So first, I'm gonna just inspect the patient. I'm gonna supply the patient with oxygen, monitored by the pulse oximeter, and I'm just make sure that there is an IV cannulation, and then I'm gonna check for the pulse, and I'm gonna inspect and palpate and percuss, auscultate the chest, and then
So, review what? Yes, go on.
review the vital chart and the investigation that was done to the patient, beside supplementing the patient with oxygen and guided by the pulse oximeter. And then I'm going to check the observation chart as well.
Okay. So from professional point of view, what you miss?
Introducing myself to the patient.
No. This is ethical point of view. Like, who is best person in your hospital to treat this patient?
Pulmonologist.
Okay, all right. So it is important, of course, can be chest infection, can be lung atelectasis. You will ask for chest X-ray, arterial blood gases. If you give chest X-ray to you in this station, so it is normal. Arterial blood gases can be normal. It is, don't forget to consult chest physician. All right. So can this scenario will be pulmonary embolism?
Not in this specific patient, but yes, if the patient
No,
is
we just
immobilized
speak
for a
about
long
this
time.
patient. Doctor, don't say extra knowledge. This is patient have pulmonary embolism.
No,
Why?
because it's only 3 days post-operative.
All right, okay. So in some patient, not this patient, can pulmonary embolism occur after 3 days?
Yes, if they
Oh,
have a major orthopedic operation like intramedullary nail, or the patient has cancer and they were immobilized for a long time.
okay. So bedridden, whatever. You know, this is percutaneous embolectomy is done in Egypt once, as I know, in the center in Aswan for fat embolectomy for patient after orthopedic operation. Maybe nowadays common. All right. So how to diagnose pulmonary embolism? Because we don't how to diagnose pulmonary embolism.
CT pulmonary angio is the
No, doctor,
diagnostic.
relax. Oh, sorry. In exam, we speak in the practical point of view. So
First, I'm
the
gonna do.
difference, I tell you, all the student in exam knows the question. All student exam knows the answer, but some fail and some pass. So how to diagnose pulmonary embolism? I don't ask you how to confirm the diagnosis. If you ask you how to confirm the diagnosis of CT angio, but how to know this patient or how to expect this patient have pulmonary embolism?
First, with the ABG, I can notice if there
No,
is
doctor,
any.
before ECG, relax again. You start
Okay.
clinically by history of dyspnea, by examination, the patient confused, by lab investigation like D-dimer, by arterial blood gases, by low oxygenation, and what else you need to tell me? Just start again. So how to diagnose?
Okay, so clinically, if the patient is dyspneic, hypoxic, and I'm gonna check for the ABG for any ABG abnormalities, ECG, as well
Okay.
as lab in D-dimer, and then I'm gonna just the gold standard to confirm the diagnosis is CT pulmonary angio.
Okay. So don't jump to the confirmed diagnosis. So if you ask you how to diagnose this disease, so from history, from examination, from investigation. You mentioned arterial blood gases. Can you tell me how to do arterial blood gases, please?
From the femoral artery, just
Yes.
mid-inguinal point, and
Mm.
they can access as well the radial artery. Heparinized, it should be heparinized, and I'm just
Okay.
update.
First, don't give option, either femoral or radial. What I ask this question because Hubernian syringe. After you take a sample, so after that, what you will do?
Just put it in the. We have just the ABG
No,
scanner.
no. Relax, doctor. After you take a sample, you need to put a pressure. For how long?
It's ideally it should be 5 minutes.
More than 5 minutes. Why more than 5 minutes?
This is the bleeding time that
Bleeding
for
time is
the
5 minutes. You must be more than 5 minutes. If you don't have a time, you don't stay 5 minutes beside the patient. So you can ask the nurse, you can ask our any medical student, any staff, any relative, just to compress more than 5 minutes. Okay. So don't forget it is heparinized syringe. All right. So after that, we have chest X-ray. Okay. So if anyone enters the exam before from the group, no one. Okay. Okay. So Dr. Khalid, in your
هذا
station, in your
مهم.
exam, is coming to you, is this which scenario, the first or the second?
اللي جالي كان بالمونري امبولازم تاني أول واحد
You are the last exam or previous exam?
شهر 11 اللي فات
Okay. I
مم.
don't remember exactly just to avoid misunderstanding, but I just need to tell you, usually we use this scenario after 3 days. But you know what is the student tell us? All the student, what they tell us?
pulmonary embolism أكيد
Okay,
معلومة.
we use this in the last 4 exam or 3 exam all over the world, and we found if we have 400 or 400 students, the 400 students speak and they discuss with us pulmonary embolism and the sign of pulmonary embolism, and some also speak about anastomotic leak. Okay, so although we just change a little, just 3 days, so it become different issue. Okay. So it is important to note that. All right. I think another one elevate his hand is Dr. Muhammad Ragab. What you need to ask?
I have this station my exam on March 2024, but not
Yes.
was anastomotic leakage.
It is what? It is what? It is what?
This station like this station on the screen now.
And can anastomotic leak?
Yes.
So what is the operation done for this patient?
Hartmann.
Hartmann. Okay. So if you see, we have. Are you working surgery, Dr. Ragab, or you are still?
No. I work in surgery.
You work in surgery. So you see this is a slide. You see this slide.
Yes.
So you know Hartmann, we remove the area and put the 2 ends outside.
Yes. No,
So
no, we close one and put one with stoma outside.
Say again. We close one. You make it down.
Yes, you close the distal and the proximal.
Yeah,
part,
this is the old. This is the old technique, doctor. This is done 10 years ago. Now, because in the past, if we close it and put it down, sometimes you don't found it. So nowadays we put the 2 ends outside just to be easy for the surgery.
Yes.
So you have Hartmann patient, Hartmann procedure patient. So how you mentioned that it is anastomotic leak? How it comes?
No possible to the patient.
No. You have this station. The patient have Hartmann procedure. We don't make anastomosis to have anastomotic leak. I know that you are correct because all the students say that. But
yes.
Because some of the student is still in Houseman, so they don't know what is Hartmann. Okay, but if you remember the Hartmann,
Dr. Shirin, maybe.
Yes.
Sorry, Dr. Shirin, maybe the only thing to think about is the retracted stoma inside the abdomen. That's it. But anastomotic leak is not. It is not logic.
All right. Okay. Case. So actually, most of the scenarios in this colonic surgery, we don't have anastomotic leak because even if we have anastomosis, we have colostomy before. So the food is not reached there. Okay. So Hartmann, no anastomotic leak. What is called left hemicolectomy must done with covering colostomy, no anastomotic leak. I just make in this picture because I know that we don't put a colostomy bag in some centers, so I make it right hemicolectomy because it's traditionally. So again, Dr. Ragab who speaks. So what is the response of examiner if you mention anastomotic leak? Have any response or he ask you something or what?
Yes. Only bad facial expression.
Okay, all right. Okay, maybe it's from Middle East cultures. We have expression. Okay,
was Egyptian.
All right. Okay. So forget about the examiner impressions, but it is, of course, the patient have rigid abdomen or tender abdomen and fever, so can be anastomotic leak in other occasion, but not in this occasion. But it's okay, no problem. Dr. Muhammad Ghunaim, what you need to ask about?
In the first scenario you shared, Dr. Flynn,
Yes,
said that the patient had fever, right? After 10 days.
Because usually
So
the patient
this
have
fever
chest pain or have pulmonary embolism, sometimes have mild fever.
Okay.
Okay, it is not. By the way, it is difficult to have anastomotic leak to occur after 7 days. I see anastomotic leak in some center. Some surgeon become like more confident and he make left hemicolectomy without covering colostomy. So maybe make 100 cases all pass smooth, but sometimes one of the cases become anastomotic leak, and fecal peritonitis is fatal, by the way. What else, Dr. Khaled, you need to ask something?
معلش يا دكتور بعد إذنك هو
قول.
how to start a case of crisp examination. So أنا دخلت وقلت introduce myself وبعدين اتكلمت معاه.
هو first doctor, this patient is not critical ill surgical patient. Is have no organ failure. If you need the patient to be critical ill surgical patient, so we can make it like have renal failure or something. So so you introduce yourself to the patient. What else you need to do?
Hello, I'm Dr. Khalid, surgical doctors. Today I've been asked to examine your chest or anything. Then وهتكلم على exposure وكده. هلاقيه عنده shortness of breath. So
No. So you examine the patient first, or you give oxygen first?
I will give the option first because he's having a shortness of breath. So
Okay.
that's
So you give oxygen. So you have the exam. You enter the exam. So you put the oxygen. After that, what you will do? What you did?
I have done. حطيت الأكسجين بعدين pulse oximeter
No,
بعدين
doctor, relax. If you put the mask of oxygen, they give him oxygen.
ما ده اللي ما كنتش أعرفه بقى إن أنا لازم أوصله.
So you work your exam in hospital setting or in
hospital عادي.
Okay, so you know this is what is called in above the bed. They have something what we called it. I don't go like
Oxygen supply.
patient bed. You know that usually above the bed. If you have any picture, we can. So here you have something. You give oxygen. You have suction.
The core and
the area above, usually like this patient, you can see something, so you have oxygen. So you must, okay. So I just connect with you, doctor. So you give oxygen, and after that, you don't make the pressure. You don't adjust the flow. So this first mistake. After that, you put pulse oximeter.
Yes, put pulse oximeter and I made sure that I have connected. ادوني كده cannulas حطيتها بس على دراعه كده يعني two cannulas حطيتها.
Alright, so
بس
you have a cannula.
كانت كانيولا زرقاء كده فحطيت واحدة يمين واحدة شمال اللي هي كانت موجودة يعني.
Alright, okay. I think
بعدين
you ask about cannula, so it gives the cannula, so the patient don't have connection to fluid. Alright, after that, what you will do? You did.
وعملت بقى وانسرتت اليورينري كاثيتر وقعدت اقول هطلب كذا كذا كذا.
ده دكتور, why you insert urinary catheter?
as a type of عشان البيشنت هو البيشنت كان بالمونري امبوليزم يعني ما كانش انستوماتيك ليك بس كنت بعمل كده يعني كحاجات يعني بنعملها على طول يعني.
Okay, can, but it's not give him much, but we can check for that. Okay, what else? After that, what you will did? So they give you a catheter or what? Check the chart. This is okay. All right.
بعدين دخلت على التشارت.
So you read the chart or not?
قال لي لا، قال لي اوكي تشارت. هو سمعها لي يعني قال لي البلس كذا والبلاد بريشر كذا
all right, just to save a time. All right, okay. After that, what you did?
عملت بقى examination, chest examination, inspection, palpation, percussion. والبركشن كان قال لي وكملتش. والاوسكالتيشن برضو عملت اوسكالتيشن وقلت هجزامن الباك وفعلا قام عملت examination للباك وعملت abdominal examination سريع كده وعملت الكاف قلت له do you have any swelling؟ قال لي yes. قلت له اوكي I will not squeeze it. بس الدكتور علق لي عليها وقال لي انت ليه ما عملتش اكزامينيشن ليه؟ قلت له لا انا عملت انسبكشن وما عملتش بالبيشن. قال لي ليه انت ما عملتش بالبيشن؟ قلت له عشان عنده دي في تي فلو عملت سكويز هيحصل شوك. قال لي لا انت بتعمل برضه اكزامينيشن
So it is important doctor that what you wish to do have no mark. You must do. If you wish to do something, so for example, I wish to complete my examination by auscultation of the heart. So you did auscultation or you don't did auscultation if you say that?
No, I did not.
So you don't have a mark, you take 0. So if you need to make Hoffman sign or Hoffman test, you need to do it. Okay, of course, you know this patient is not a real patient, it is an actor, so you must be realistic. Okay, after that, what is your diagnosis?
كان pulmonary embolism.
So just a minute, is this patient how many days after surgery?
اعتقد وقتها كان 7 أو 8. انا ما كنتش اعرف يعني ما كنتش وقتها عندي المعلومه بتاعت ان 3 ايام تبقى chest infection بس هي كانت اكتر من 3 ايام يعني.
Alright, if it's more than 8, okay, still pulmonary embolism, but if 3 days it's just chest infection. So Okay, you consider is pulmonary embolism. What else you need to do for the patient, or what you did?
بس قعدنا بقى نتكلم discussion بقى، يعني خلصت خلاص وبعدين قعدت
Yeah. So
نتكلم
what
في
is discussion about? Of course, you finish all this in 6 minutes, so they have 3 minutes remaining. Okay, that's good. After that, what you did?
What's your diagnosis? My diagnosis is pulmonary embolism. How to confirm, how to diagnose the patient with pulmonary embolism by doing history examination and.
Okay, so you did history examination, so it is good. Don't jump to CT angio. Okay. All right. Good. Okay.
History examination وبعدين ECG.
No,
ECG
no.
what
I just make you just say history examination or say history of orthopnea, dyspnea, something or what?
لا I'll take history. لا I'll take history فقط يعني. I'll take history, a good history from the patient and.
Doctor, we don't have good history and bad history. If you need to, because this patient have, for example, history of DVT, this patient have cyanosis, this patient have something. This is the history. It's not a good history. And we're looking for arterial blood gases. So you mentioned what you're looking for.
ما أنا قلت I will take history examination from the patient. I'll do ECG. I will take EBG.
No, if you take a history, have no important. You take a history of something. Suppose this patient have history of DVT. The patient is on an anticoagulant. This patient have history embolectomy. Is according to the scenario given to the patient. And of course, you see the arterial blood gases.
شفتها.
So you comment on it or not?
Yes, it was metabolic alkalosis.
Okay, can. Although it is
وقال
common to be respiratory, but can maybe change it. I don't know. But it is important. Don't vague general word like I take a good history and examine the patient. Okay. So all right. So again, if you remember to diagnose DVT, pulmonary embolism, so we have clinical. We're looking for dyspnea. We're looking for like this, for example, dyspnea, confusion. We ask for D-dimer, arterial blood gases, and of course CT angio. Okay. So
هو هنا بقى كده يعني في الاكزامينيشن بتاعي ككريسب، هل انا نقصت درجات كتير؟ يعني انا اصلا مش عارف، انا خلصت كل الحاجات اللي انا عارفها، ولكن برضو ما حسيتش ان الاكزامينر ساتيسفايد من الاكزامينيشن بتاعي.
هو you have no mistake, but your word is like vague word, like general word. For course, Dr. Muhammad Hisham is good presentation, but if he's in exam, I give him good in clinical and bad in professionalism. Why bad in professionalism? Because he mentioned percutaneous embolectomy, which is very rare to be done. He mentioned, I think, what else? Something like that, but his overall he's good, by the way. All right. So it is, and they give 100% oxygen, so it is fatal in some center, but it's okay. All right. So we some consider some mistake is not related to knowledge, is related to your professionalism. You are much working because we have some work for long time, some work for short time. This what happened. Okay. After that, is anyone need to ask? So shall I continue? Okay. All right. You can ask. Yes.
هو انا دلوقتي في الاسسمنت اوف circulation بعد ما بعمل examine of the heart by listening and doing ما اقولش ان انا عايز اعمل insert a two wide pool cannula and insert the urinary catheter to
if you speak in management you can tell that if you speak in management, but we it is according the script is according to the situation.
So
okay.
I don't need to mention that in my examination in 6 minutes.
Doctor, examination is examination. Examination, this is not a station of examination. This is for evaluation. So to evaluate it, so you need quick history, examination, and after that in management, you will ask what you will do. But in this station, because we put oxygen mask and that, so this is why we insert oxygen mask. Okay, what you need to ask about?
Sorry, Dr. Shirin, if I had this, I'm Muhammad Ghani. If I had this station in the exam,
yes,
I will still have two two examination stations and 3 critical care stations or يعني
say
if I
again,
had
say
this
again.
one يعني like this case أو this station I will
Yes,
still have 2 other critical care stations, right?
doctor,
This is not examination.
we have 3 station, and this 3 station is physiology. The physiology
okay.
is done by either intensive care doctor or physiology doctor. So the usually intensive care or anesthesia doctor, he do what he did in practice. In practice, the anesthesia in big hospital, they have a clinic called the pre-admission clinic. This is common in European country. In this clinic,
Yes.
he make pre-operative evaluation of the all patient for tomorrow or day after list. So this is station in this scenario is how the anesthesia, if you look into your hospital to the anesthetist, what he will do for the patient, this is the correct answer.
Okay.
Okay, I just have some notes. After that, we can open discussion. So what others in this station? So in this station, we have a lot of things. The first thing is X-ray. So I just any volunteer. So the first is
أنا
this.
ممكن share.
You share it or not? You see it or not?
Yes, I can see it.
Okay, what is this? Of course, in exam, we have the name and the view and all this. So this is normal, abnormal.
Normal.
So this is
This
normal
increase
X-ray.
pulmonary, yes, normal. Yes.
Yeah, but it's normal. What is this?
This right wide mediastinum
If this due to trauma, what it could be?
could be a traumatic abdominal, traumatic aortic dissection, descending aortic dissection.
Yeah, descending. Okay, what is this? Look to the right
This
lung.
right side pneumothorax, right side
Tension
pneumothorax,
pneumothorax. Okay.
tension, right.
All right. So right, the lung is collapsed and tension pneumothorax. So this is the common what you have in exam. What is this?
There's air under the diaphragm, maybe subphrenic abscess or perforated viscous.
No, doctor. You see in your life subphrenic abscess?
No, I'm a cardiac
Okay.
surgeon, so.
All right. If any one of general surgery see in his life subphrenic abscess, so the common
Yes.
is perforated. You see subphrenic abscess.
Yes.
Okay. It is common or perforated viscous is common.
Perforated viscous, of course.
Okay. So perforated viscous is the first option. Don't say some rare. Okay, and some doctors they say something. They have a sign here called Chilaiditi sign. It is in some patients the colon in becoming this area, but all this is funny. Don't tell in our exam. Okay, so the X-ray is easy. After that, we have investigation in respiration. Of course, this is normal respiratory function test. So you can have tidal volume, inspiratory, expiratory reserve volume. It is important to know this. It is important to know that the inspiratory capacity, the vital sign is all, and if you add residual volume, become total lung capacity. At least you know the names. So we don't need the number, but at least you know the shape of the curve, and it is respiratory function test. Lung volume, of course, you know, vital capacity is inspiratory reserve volume, expiratory reserve, and tidal volume. Of course, residual volume is volume of air remaining in the lung after maximum forced expiration is about 1 liter 200. Residual volume is only lung volume, can't be measured directly because it is impossible to complete empty the lung for air. So this volume can only be calculated. Of course, the dead space can be anatomical and physiological. As you know, anatomical is like trachea, like busway, upper respiratory. And if some alveoli is not working, we call it physiological. Minute volume is tidal volume, time respiratory rate. A normal person is minute volume is 450 because it is 4,500 because it is the breath per minute and the tidal volume. Lung volume, not volume inside the residual volume, measured by spirometer. Residual volume can't be measured, just by calculation. Forced expiratory volume is the first 1 second of forced vital capacity in the lung is normal 0.75. This is age dependent. In restricted lung disease, the forced vital capacity is smaller than normal, but the forced expiratory volume first second is large in comparison. So the ratio can be higher than normal. We don't ask
دكتور
you in
شيرين
this much detail. Yes?
دكتور شيرين الحاجات دي بتتسأل كتير يعني
No,
البلمونة فانكشن.
no. Just to have an idea how to draw the curve. Okay? How to draw the curve, how to draw it. Like tidal volume and respiratory exercise, just to make it. Okay?
يعني هيديني ورقة وقلم أقول له ارسمها يعني؟
Yes. It is common. I do that many times, by the way. So it is very common because what you do, if you ask, usually you say, I will do for the patient. I think Dr. Hisham, he say, I will do respiratory function test. You did so that, Dr. Hisham? You tell me, I will do respiratory function test?
I don't remember, but I think.
Okay. So once he did, so I give him paper, so can just do the normal respiratory function test. So you must do it. Okay. I don't have much detail about this. Of course, sometimes you ask about oxygen dissociation curve and shift it to the right, shift it to the left. So it's important to know that. I just tell you what is important for us or for me. This is what is important if we ask. You know, in fluid therapy, is anyone work in burn? Okay, so till many years, if you give fluid to the burn patient, we have this equation which is called Barkland formula, 4 milli percentage burned by weight. Usually we have burn station in physiology, by the way. So this is first 24 hour, half 8 hours, and the remaining 16 hour. So for example, if the patient have burned area 19, so this is the amount. But from 2 years ago, they say if the percentage of burn is more than 20%, so it is better to change the equation, but instead of 4 milli to become 2 milli. Is anyone know that, or it is new for you?
No. They actually said that 2 milli normally. If it's in children, it's 3 milli, and if it's electrical, then it's 4 milli as well. So it's 2, 3, and 4. Depends on the type
but now if you make Barkland formula, if the patient have 25% burn, so use 4 milli or 2 milli?
2 milli.
2 milli. So again, so this Barkland formula, so it is important because we ask about this. So it is, if I say to you it is more than 20%, so you make it 2 milli by 25 times the patient weight.
Do we have calculator?
No, it is just write it. You don't need to make a mark, but just to say 2 milli. He asks you, he just need to know that it is 2 milli. Because this is, I think it is in the last edition of ATLS guideline. Before that, it is still 4 milli for all. For hundreds of years, Barkland formula is 4 milli for burned area, for body weight, for many years, maybe 100 years or more. But last 2 years, they found, because they found, suppose the patient have 50% burn and they even have 50 kilo. So if the multiply 4 by 50 by 50, it reach about 20 liter. So it is very, the patient will die for pulmonary embolism. Okay. I just have few slides. So this is cerebral circulation is not problem, coronary is not. Okay, the second topics you can ask it because usually you say it is ECG. So you need to know what is BQRST. So of course P for atrial depolarization, QR for ventricular depolarization, and T wave for ventricular repolarization. So if anyone know what is the important ECG you need to know for the exam, what is the important ECG you need to know?
AF.
AF, what else? Hypothermia.
Hypothermia, like D wave.
Okay.
Screen.
Hyperkalemia.
Hyperkalemia, hypokalemia. Okay. So first, hypothermia. Hypothermia may be common in Europe, but not in our country. So they can patient have what we call the G wave. They can have prolonged PRQR, can be have artifact due to shivering effect, can have ventricular ectopic, Of course, it can be ended by arrest. So this is hypothermia. First topic is important. Second topic is important, hypo and hyper. So again, hypo is mimic ischemic heart. So you can find T wave inversion, ST depression, prominent U wave. Hyper, usually tall, tinted T wave. Is anyone know how to treat hypokalemia?
Hypokalemia replacing just it's a support of the patient fluid and replacing of the specific management of hypokalemia, either replacing the potassium in a peripheral line or a central line.
What is the rule of 40? If you know the rule of 40, 40, what is this?
It does not exceed 40 millimole per hour if it's in a central line.
Okay. And
in the peripheral line does not exceed 10 millimole per hour if it's peripherally.
Yeah, say again, it is 40 milli per hour.
40 millimole per
I think
hour.
we never give potassium in a peripheral line, I think.
Yes,
No,
okay. No, just
In reality,
forget the
yeah.
peripheral line. What is the other 240? The maximum is 40 millimole on 1 liter, and must be the urine output is more than 40 per hour. 40 mil per hour. Of course, the urine output is 1 milli per kilogram body weight. So
40 milli
just
equivalent.
check it. 40 milli in potassium, milli equivalent and millimole are equal because potassium is monovalent. Okay. So how to treat hyperkalemia?
Just the insulin glucose
Insulin. Okay, so
yeah.
usually we can give it through the pump, so insulin glucose infusion. Okay, so after that, I think we have, this is hyperkalemia is very important. Of course, we discuss this. This is finding in pulmonary embolism. So S1, Q3, T3, and S wave in lead 1 and the Q in lead 3. So this characteristic. Sometimes, in not all cases, they have B pulmonale is right atrial enlarged. Of course, sometimes if you ask you, if you collect the central line to the monitor, what is the measure they give it to you? If you have central line and connected, so what is the measure they give to you? What is the curve give it to you? First, just anyone, what is the normal central line?
Normal 8 to 12.
What is the unit?
Millimeter mercury.
In your hospital, we don't use millimeter mercury. What we use?
5 to 10
centimeter water.
Okay,
water?
so centimeter water. So you mean that we put in this tube or this line water?
Yes.
No. If we put water and go to inside the body, the patient have hemolysis and will die.
Saline.
Okay. So although we for many years in our country or some countries we believe that the CVP is measured in centimeter water. But actually, we don't use water. If we use water, the patient will die. It is centimeter saline. Okay. This is important because if you are in country and they tell him to bring water to measure the central line, you will kill the patient. Okay, so if you connect it to the central line, so they give you this picture, what is called what is called jugular venous pressure measure, and jugular venous pressure. It is important to know that A, C, V, and X and Y. A is the atrial contraction. C is the atrial is ventricular contraction, and the V is arterial venous filling, and the two descent is X and Y. One for atrial relaxation and tricuspid move down, and Y is ventricular filling and empty of the right atrium. So maybe this picture, so it is important at least to know how to draw it. Okay. It is important to know ejection fracture is the stroke volume over endostolic volume, and the normal ejection fracture is 55 to 70. We don't have 100, so the normal people is 55 to 70 maximum. Stroke volume over endostolic volume. Of course, stroke volume is volume of blood pumped by the heart in each beat, so whether right or left. Endostolic volume of blood remain at the end of diastole. Okay. The last slide, I have it. So it is important to know the drug acting in the kidney. Of course, loop diuretic act in the loop of Helen, and loop diuretic is easy. You know that thiazide act in the distal convoluted tubule, acetazolamide act on proximal convoluted tubule, mannitol act in the proximal convoluted tubule. And of course, the common we use is aldosterone act in distal convoluted tubule, antagonist to aldosterone. Aldactone is against aldosterone, which act in the distal and sometimes collecting tubule. Okay, this is all from me. So I just need to confirm first that this station is managed by physiology, intensive care, anesthesia doctor, not a surgeon. So he's not interested to know anastomotic leak. He's not interested to know the detail of the operation. Okay?
Okay. Okay.
So now we just open for discussion. All
May
right.
I ask a question, Dr. Shireen,
Okay.
in regards of the pre-op